Welcome, everybody, to the Pediatric Depression Screening and Management Guidelines Town Hall for the Physician Enterprise. We are here on May 1st, and May is Mental Health Awareness Month, so it is very apropos that we are launching this town hall today. So let's go to the next slide. Great. So a few words about our Pediatric Ambulatory Collaborative, and a big thank you to our collaborative members who have dedicated their volunteer hours in guiding us to what is the most pressing challenges in the management of chronic illnesses in pediatric medicine. And they're laser focused on creating healthy adults, which is such a lovely, wonderful approach to medicine because understanding their own role as pediatricians, family medicine physicians, and APPs has been key in identifying some of the topics for 2023. And those are listed in front of you. Now, of course, if you are interested in joining the Pediatric Collaborative, we welcome you with open arms, and we'll be sharing that information with you.
Yes, we will send the information out to make it available. If you would like to join, I'll also put it in the chat. So thanks.
Thank you, Rachel. Next slide. So we're here to talk about screening and management of pediatric depression, and we cannot even begin to fathom this work and all that it takes to make it happen without some gratitude to the countless subject matter experts, leaders, as well as our clinical teams that have come forward to provide their guidance and their hours and their dedication to this work. So first of all, big thank you to our ambulatory quality team represented by Deborah Rockman and Kelly Batonio. And Kelly will be speaking to us shortly about all the ways in which we are going to try to aspire to a wonderful goal for screening and creating a solid follow-up plan for depression in our patients. And then, of course, a big thank you to Rachel Lytle, who is our System Director for Clinical Standards and Variation Reduction, John Kanishi, who is also a System Director within the PE, and our fearless leader, Dr. Gary Greenswag, who helps us achieve the impossible across the physician enterprise. And our clinical work group members, some of who have joined our call this afternoon, evening, depending where you are, big thank you to you because this work really belongs to them. We are merely the venue for showing this work and making sure it reaches those who need it the most. And of course, our partner teams as listed below. Next slide. Okay, so what should you know about these pediatric screening and management guidelines, right? So we are not going to do a deep dive on what the guidelines say. We trust you as adult independent learners to review those guidelines and apply them as you see best. But this is a quick primer on what you should expect. So one, the fact that screening is recommended annually for all patients 12 years and above who are average risk, right? And also two, treatment for those patients found to have mild and moderate depression includes prescribing lifestyle modification, oral medications, and perhaps the combination of the therapy. And we do feel that this is part of the work that we start in primary care, but then reach out to our behavioral health teams for assistance as well as collaborative approach. The recommended screening test for adolescents is the PHQ-A. That is the preferred test. If it is unavailable, PHQ-9 can be acceptable, but we'll go through in another slide in just a minute why PHQ-A is the recommended scale for measuring, screening, and then also follow-up planning. Treatment, mild depression, think about it as anywhere from 4, a PHQ-A score of 4 and above, without secondary psychiatric disorders. Or we're going to talk about moderate depression, considering 3 options: therapy, oral medications, or the combination of the 2. Next slide. will show us a little bit about that PHQ-9, PHQ-A that we talk about. So the PHQ-A is the modified version of PHQ-9, right? So it has 9 questions, Likert scale 0 to 3, and really focused on addressing symptoms in the past 2 weeks. And then the second aspect of it is really those bottom 4 questions that go in the guidelines. We address why they're important to make sure you review them, because not only do they address how difficult it is for our patients to move through their day, achieve all the activities and tasks they need to do, but also to try to gather how severe is this and how much of a difficult time are they having? And third, about the suicidality or any previous history of suicide attempt. Next slide. So what does treatment entail, right? And when we think about treatment for mild depression, as mentioned earlier, for adolescents, really it's a lot of lifestyle changes, a lot of coaching. When it comes to moderate depression, a combination of lifestyle changes, cognitive behavioral therapy, as well as medications may be appropriate depending on the patient. And in the guidelines, you will find a couple of different tables. One of them is shown here. It is about how to start a medication, what is the preferred medication, and then how to taper or switch if the desired medication effect is not achieved. And the reason we did this is because, me as a primary care physician in internal medicine, one of the things I always ask is I'm willing to start, but what am I expecting, right? In week 1, week 2, week 3, and then all the way to week 6, which is the desired effect should be available. But if there is no desired effect or minimal effect, what should I do next, right? Which that table is key. And this information came straight from the GLAD PC toolkit, which is an evidence-based guideline. And it is important that you review this, because while fluoxetine is considered #1 medication, dose increases may be appropriate depending on whether the correct amount of response is achieved by a starting dose or increase. On the next slide, what you will see is that it is important for us to understand that while these guidelines have been built, well, what are your next steps, right? What do we want you as our primary care physicians and APPs and pediatric physicians and APPs do with this guideline, right? Because guidelines are good. They are somewhat static, but this guideline's a little different. We want you to review it. It's available in 2 places. So if you click on that upper link, it goes straight to the Google Drive. Or you can click on the physician resource library, which gets you to the physician resource library and gives you all of the tools that are listed. If for some reason you feel or you are interested in doing a deep dive into all things pediatric depression management and screening and management, I should say, you can click on the GLAD PC Toolkit link. It will take you directly to the website. It is open source. You should not have to pay for anything. It is available for you to peruse. And also, we have specified the link to the screening aspect for children and adolescents. The second part of this work is to come forward in the coming months, going to be a similar guideline for adult depression. Now, we want you to read these. We want you to consume them. We want your feedback. So if you were to go to the physician resource library, physician enterprise resource library, I should say, there is the ability to provide us feedback, or of course, you can always email myself, Ankita Sagar, or Rachel Lytle to give us feedback, and we're happy to take that. Okay.
I just wanted to take a moment so that people knew where to find it. If you don't know to scroll down to provide us feedback, it's at the bottom of our page, just FYI. And then also to add to what Dr. Sagar is sharing, the pediatric, the guidelines are here in addition to the resources, and also providing the information for the actual professional society guidelines.
Thanks,
if you don't,
Rachel.
just in case people are looking for it.
Yeah, that's perfect. Thank you. Okay. And on the next slide, now that you have consumed the guidelines, you've read it, now you're an expert at it, right? What do we want you to actually consider? We want you to consider three things. One is counseling patients, right? A lot of times, especially when patients are struggling, you guys, of all people, may appreciate this. They may not be ready on the first visit, but reapproaching screening and feasibility of treatment is important when we see them. Um, Second thing is, and we'll talk about this in just a little bit, is the National Network of Child Psychiatry Access Programs, which are available. It's a collaborative care program at no cost to patients, no cost to you, but they provide a coaching model that allows for us as primary care physicians and APPs to outreach to social workers, psychologists, psychiatrists to really make sure that we are starting off at the right foot if we are considering treatment for depression. And then third, join us. We would love to include you in our Pediatric Ambulatory Collaborative because the more we hear, the more we can appropriately address concerns. And also, we want to highlight and recognize your voice and your ability to really lead the way in what should be a priority topic for pediatric medicine. Okay, next slide. And I will be handing this off to the lovely Kelly Batonio. Welcome, Kelly.
Thank you. All right, so let's talk about the depression screening as a clinical quality goal for the national goals, national measures. Next slide, please. So just to briefly cover the definition, we have aligned ourselves with the CMS preventative care and screening, depression screening and follow-up definition. But for FY24, we're only going to be looking at the rate of screening only. And this is because we don't have all the data. We don't have access to all the data. A lot of work went into doing edits and making sure that the EHRs were able to capture discrete fields for the screening and the follow-up plan. However, our little cyber attack put a little delay in that for some of our Epic markets. And so in order to be fair, we're waiting until they're able to join and we're able to collect their data as well. So we do, all of the depression screenings were already embedded into each one of the EHRs. And so we do have that data, and that's what we'll be using to start with in FY24. And so what we're looking at is for patients that are equal to or greater than the age of 12 during the measurement period, which is July 1st, 2023 to June 30th, 2024. Was there a depression screening completed within, the previous 365 days? And of course, those that are excluded will be patients that have a diagnosis of depression or bipolar, those that have died during the measurement period. We're only looking at the patients that are affiliated with Common Spirit Health Physician Enterprise because we have access to their data. And exceptions would be patients that refuse to participate or have a documented medical reason for not screening. Okay, next slide, please. Our approach to this, again, is because of our data challenges, we will just be looking at the screening portion of this measure. However, as soon as the data becomes available, and we're expecting it to be fully available in January, as soon as it becomes available, we will be reporting the results on the scorecard, but they won't count towards the FY24 goals. The FY25, because we'll have the data, we'll be looking at the full measure, so depression screening and follow-up if there's positive results or positive screening. We'll also be looking at equity across our demographic groups. And each year we'll be, working on our toolkit to make sure you have resources to be successful. We'll also be evaluating the potential outcome for a measure as an FY26 goal in FY25. And in FY26, one of the, I know you're going to love this, one of the measures we're looking at is depression remission at 12 months. So if it's endorsed. Anyway, so, and of course, whatever is chosen, we'll build out those toolkits as well. So next slide, please. So we worked with a group of providers or clinicians, behavioral health folks, as well as quality and frontline staff to come up with key strategies for addressing this measure. So you see the 5 key strategies here, and we'll go a little more in depth with those, but basically it's establishing depression screening as a practice priority, optimizing the workflow and to support depression screening follow-up, engaging and supporting patients in the self-management of depression. And those pretty much are what happens at the clinic level and what happens with your staff. The bottom 2 is more for our providers, and that's defining the workflow for provider interpretation and follow-up of positive screening, as well as deploying evidence-based approaches to diagnosis, treatment, and ongoing management. And I want to give a special shout out and thanks to our clinical. I know I always screw up your team name. I'm
clinical
so sorry.
standards. You got it. You got it.
Clinical standards and variation team, because they're really heading up the work on the bottom 2 strategies. Next slide, please. So our next steps, well, we had our strategy work group, and we actually have 2 more coming up, and one tomorrow to address the best way to deploy the tools and what tools, what additional resources we may need. And then on May 11th, Dr. Sagar will be leading a work group of providers on the guidelines and treatment and diagnosis monitoring guidelines. So we have some resources already in the works, and we'll show you some of those. And then the orientation to the resources will be in a kickoff webinar in July. Next, please. So some of the resources we have education for our frontline staff. And that is now being applied to Pathways, and so will be available shortly. We have a depression screening workflow for our clinicians. This was vetted out with our quality leads, as well as some of the providers, to ensure that we're following, what our clinics are doing or what we would have them to do. And then we have some community resources for online connections, basically as a handout or a portal handout for your patients with active links to community resources. Next slide, please. We actually, just so you know, we actually finished filming a introduction of how to do a depression screening in the clinics with the help of our Stockton clinic. We are in the process of also creating a video on the importance of depression screening within the clinic, with the primary care clinic environment with Dr. Sagar and Dr. Piazza. There's lots and lots of resources that we're adding to the toolkit every day. So look forward to that orientation in that webinar in July. We have already determined the baseline for the depression screening data, and we're now establishing what would be our proposed goals for improvement over baseline. And this will be looking at it. The goals will be established by enterprise, division, and market level. You as a clinic will have to determine your own goals. So we are submitting the depression screening and follow-up measure for a BOST goal approval at the June meeting. We do anticipate that even if it is not approved as a priority goal, that it will still be on the scorecard because it is very important work. And then we're beginning to work up on the follow-up rates as discussed earlier. Yeah. Next slide, please. Okay. So I alluded to you can go to the next slide, alluded to the fact that we had a whole bunch of work to do, and it took about 18 months, and we're still not complete there. Now we're looking at optimization to get our EHRs ready to collect the data, meaning we had to have discrete fields for the follow-up items and for the interpretation of the screening. So you can see here that every EHR is live with the exception of our EPIC markets outside of Kentucky, and we do anticipate they will be live in the later part of May or the beginning of June. And the holdup there now is education, but then they will be live as well. I'll get back to the depression threshold in just a moment. For the follow-up, for all scripts, we're looking at optimizing the follow-up. It is already built. It just needs some optimization because there's too many clicks, and we want to make it as streamlined and as easy as possible. For Cerner, their follow-up is live as well, but the Virginia Mason in California, Nevada, and Arizona, but Virginia Mason is still building. And of course, we're optimizing there with the alerts and auto calculation. For eClinical Works, it went live last June. The interpretation fields and the annual wellness visit links were updated in November. And we already talked about EPIC. So now the depression screening PHQ-2 threshold to complete a PHQ-9. What we discovered when we started looking at all these EHRs is there were different recommendations within the EHRs when you hit a score of, let's say, 1, 2, or 3, to then complete a PHQ-9 to continue on to that. And so in order to kind of streamline that, we are making a recommendation. We're trying to make a recommendation to standardize that, and we have a meeting about that tomorrow. So, okay. And I think that was my last slide. Are there questions? A lot of information, I know.
That was great, Kelly. Thank you.
You're welcome.
Rachel, do you want to talk a little bit about the NNCPAP programs, and then we can get everybody's questions and thoughts?
Sure. So this is a really great resource in addition to the guidelines for pediatric depression screening and management. We kind of discovered this resource, and we'll kind of talk a little bit about what that means to you as primary care providers. But really, if you are treating your patients and find that there are additional resources and support needed, the National Network for Child Psychology Access Program is something that you want to register and enroll for. So what is this? The NNCPAP program, for short, is a multi-state program, and they're grant funded in each individual state, not all 50 states, but most. And it's really a collaborative care model that allows you to contact this resource in your state and potentially get peer-to-peer consult, whether it be from a psychiatrist in your area that's affiliated with the NNCPAP, vetted community resources. They offer training and education in some cases, care coordination and screening. This is a pediatric resource available in your state. Most cases 0 to 21, and in other states we have found up to age 25. And I'm just going to share a video. This is about this provides a good understanding of this program in Texas, but again, that's an idea that can spread out to other states because it's a resource that's available. So the video is catered to the Texas market, but again, this program is available in other states. It gives you a good view of what the National Network for Child Psychology Access Program can offer. So just a short video to watch.
Pediatric health clinicians throughout Texas say that using CPAN helped them be a better doctor. CPAN is the Child Psychiatry Access Network, and CPAN is here to support you in caring for your patient's mental health at no cost. CPAN is a state-funded service that provides real-time, peer-to-peer psychiatric support, and consultations may be billable. CPAN also offers vetted, personalized referrals within 1 business day, so you can get your patients the help they need quickly and with confidence. CPAN knows that developing a procedural memory for something as complex as mental health care requires support, and we're here to offer that support to pediatric health clinicians. Thousands of Texas pediatric health clinicians are using CPAN. You can join CPAN in about 10 minutes and get the answers you need to help your patients with their mental health concerns.
A rural Medicaid patient of mine had an eating disorder and she needed a counselor. I used to give my patients a resource and referral list that wasn't vetted. It was time consuming and hard for parents. Recently, I had my nurse call CPAN. By the end of the next business day, I had a specific list tailored to my patient's needs and insurance, which I could share with their family. Enrolling in CPAN today gets you immediate access to referral support and peer-to-peer psychiatric consultations.
You can ask CPAN to find patient referrals for you. With single business day, local resource vetting, CPAN keeps work off of your staff's plate to ensure your office stays as productive as always.
Referring my patient to an anxiety and depression specialist would have taken months, but she didn't have to wait because I called CPAN. And I collaborated with the psychiatrist on a treatment plan, and she answered all my questions. It was a Friday afternoon. They called me back within 30 minutes. With CPAN's guidance, I was able to help my patient that day. I had more confidence because I know I can contact them as many times as needed, even for the same patient, and get step-by-step guidance. You're welcome.
When you call CPAN, you're talking to board-certified psychiatrists, mental health experts, and clinicians. We offer peer-to-peer, timely, evidence-based mental health guidance. Together, we can provide the best mental health care to children under 1 roof. We're here to help make sure you're supported for any mental health issues your patients face, to give you the support you need and the confidence you need with this patient to be ready for the next one. You maintain the provider relationship, and we will give you the support to do it.
When I was in my residency, I didn't have extensive training for treating ADHD, anxiety, and depression. If it were pulmonary distress or diabetes, I've seen it, done it, and taught it. CPAN has really helped me get comfortable with providing evidence-informed, family-centric solutions regarding the mental health of my patients.
CPAN also offers free training to give you the skills you need to build your expertise. CPAN offers free CMEs and Project Echo case study learning on a wide variety of mental health topics, such as autism, ADHD, trauma, and suicidality. CPAN is here to help. Enroll today and join the thousands of Texas pediatric clinicians in caring for the mental health of our children. Thousands of children and families have been helped through CPAN. Let us support you to take care of even more.
So I'll kind of stop there. That gave a really good idea of what this program that's available offers. And so what we did is we added this information inside the guidelines, but we wanted to make sure that the programs in the states that you're seeing here, because they're really what's within our Common Spirit footprint, are active, understand a little bit more about what services are offered in those states and those areas, the ages, and then how you all as providers can get registered. As you will see here, and like I mentioned before, this program is not available in every state. Arizona, our pediatric collaborative team found out about this helpful resource and has reached out to try and get this program also in their state, which again is a grant funded, HRSA grant funded program. So that is, I think, a little bit more to come. But it's available to you and it's a no cost service. So we just want to make sure that that's also on your radar, and it is something you will have to get registered for. Just like we shared the guidelines, you will see that the resource for NNCPAP is also on the resource library. And what I've done also to try to make it easier for you, on the website, and again, also in the guidelines, we have put that list out here for you. It's a little small and I apologize, but when you go to the guidelines on the PE resource library, you look for resources, this information, the states are on the side, and then the information about the program, who to contact, and then on the side here, most importantly, is how to register. Just like they mentioned, registration doesn't take you a long time, but it does allow you access to this program in your state.
I guess I'll summarize our presentation a little bit. So, we have our leaders leading the way for ambulatory quality and making sure that everybody's has a excellent workflow for screening, right? Then we have our guidelines, which go through who to screen, what to use as screening tool, and then also if mild depression is diagnosed in a pediatric or adolescent patient, what to do. If moderate depression is diagnosed, what to do. Goes through medications, titration of medications, side effects, what to expect over 6 weeks of initiation of treatment. And then the guidelines also delve pretty deep into the NNCPAP programs, which are free. Again, they're free for you to be able to leverage what is already available through the federal and the state government plans. And our goal really is at the end of the day to make sure that when we ask our teams to screen, we're also giving you resources of what to do when somebody screens positive, because we understand it's really important. Questions? I see Dr. Greenswag has joined us on video.
I don't have a question, but just as a comment, and this has really been, it's a challenging topic and one that I think people are just a little careful to get too close to. And I see Dr. March is on the phone and other folks that have kind of guided this process. And it's really been remarkable to come up with something that's digestible. I'm a family physician and not a pediatrician, but in my day had lots of kids in practice. And I think this is something that with a bit of coaching and the network that Rachel shared that we could do. And so I just thank people for bringing this forward and for all the people who helped. It's amazing.
Okay. I think folks are still wrapping up their day. Rachel, do you want to talk a little bit about the upcoming events?
I can get my screen back together. Sorry about that. Yes, so in addition to the town halls, of course, we're going to continue to distribute this information, and we encourage you all to join our events that are coming up. So today was the town hall this morning and this evening. Thank you for joining us. We will be doing a grand rounds on this topic in July on the 28th. And then I should probably flip those around, but before July, we will have a lunch and learn. That's 2 sessions over the Central Time and Pacific Time noon hour to also discuss the guidelines and hear from some of our folks that were in the work group and also that are in our pediatric collaborative. So a couple of really good opportunities if you missed this, or to share with your colleagues to join us for those events. And we will also send out the slide and the recording.
Thank you, Rachel. Dr. Shof, I see your comment in the chat, and we're going to double check that link to
Thanks.
make sure that link is accessible. So thank you for flagging it for us. We sincerely hope you can join us for the Lunch and Learn, which is much more practical, on the ground approach, meant to be more of a workshop discussion, which is in June, as Rachel mentioned, and we are having our July grand rounds dedicated to pediatric depression guidelines. So as you can see, this is the start of a conversation, certainly not the last one we're going to be having. Okay, great. And really a big thank you, I echo from Dr. Greenzweig's words, to everybody who has done work with us to bring this to fruition. So thank you, thank you.